Okay. Should be good to go now.
Yeah, okay, thank you. So actually, since we just had also a discussion recently about the discharge summaries versus death note and what counts, I thought it would be good to continue on the prior topic of neurocritical care, like level of consciousness assessment and how that can transpire in your note, but also documentation and coding and billing in general. That's probably not something that has been covered by the neither the neurology nor the neurosurgery residency program yet. So I can give you a little bit of um, an overview on the proper documentation in EPIC of the discharge summary or the of a dead patient, as well as our um, the way we should be using neurocritical care, maybe templates for the progress notes or the admission notes. It's probably too lengthy what I'm going to show you, but you'll keep what you like and tweak what you don't. And coding and billing, I have some slides from the AANS a few years ago that I can share with you. So that will definitely cover at least 45 minutes. So let's go over that. I'll share first my screen of Epic. Here we go. And for the death note, and I want it to be interactive, of course, if Emily or anybody wants to chime in and say something different, I may not be properly telling you exactly all the steps that needs to be done at Elmhurst. But in general, for the discharge of a patient, it's better if you use a template. And very importantly, let me move this around so that you can see. Oh no, we don't see it here. But once you're typing your note in Epic, there's a label that asks you, is this a progress note, a discharge summary, a death note, or etc. There's one label that is created in Epic that is dedicated to the discharge of a dead patient. It's called discharge of the deceased patient, and that will count as both the death note as well as the discharge summary. Otherwise, we're going to be flagged that we're missing a discharge summary. So that's why it's a weird term, right? Discharge of a dead patient. Well, so that counts for both. It's good when you have the PCP address and some old-fashioned electronic health records. We're creating also a letter that would go to the primary care physician. It's quite a cordiality that we forget about, but it would be nice to tell not only the family but also the primary care physician taking care of this patient that they died during their hospitalization. Of course, the next of kin or the legally authorized representative, you can put their names here. Why are they hospitalized? So I have a drop down here um, of different lists of famous, I mean, notoriously used diagnoses like ischemic stroke, ICH, hydrocephalus, what have you. Original presentation, so you can usually go by the EMS or the HNP and put their original presentation, but be succinct, like TBI, spent 2 days in the ICU and died of a herniation, that would suffice. That's an automatic population of all the problem list, but that's only good if we are updating the problem list and putting only accurate diagnoses in it. So don't rely on it, but I like to have it in my template because then it flashes in front of me, and then I can select to remove some of them if I don't like them or add some. The hospital length of stay, the ICU length of stay are automatically calculated in Epic, and don't forget to put all the things that we've done to the patient, so the procedures like status post thrombectomy, and count as procedures, by the way, also anything like a central line, A line, endotracheal intubation, Foley insertion, yeah, it does matter for the ME if they really do, I don't know, if there was a pelvic trauma and they look at the urethra and they have lacerations there, they are not going to know if it was from the original trauma or if it was from the insertion of the Foley. So I guess every single procedure matters. Clinical evaluation for death. I wish I had the drop down. Maybe I should type it uh, in a patient so that you would see. But Usually you're called by the nurse to evaluate a dead patient because there's a lack of pulse and they're unresponsive. That's on the floor. For brain death patients, we're usually called because they say, well, now he's not breathing anymore, and then you do the whole process. And obviously, you would use a different note for the actual determination of brain death. Then you use this note to discharge the patient and say that they were dead. On exam, so I think my drop down here has like things like no pulse, no respiration, or no brainstem reflexes. When did you pronounce the patient, at what time, and the date? So why did I separate the date here from the automatic date that is on top? The reason is sometimes we're typing our note right after midnight, and unfortunately they would be giving you a wrong date of the death of the patient. So I had to separate it because quite a few times through my 10 years of experiencing all those issues, documentations specialists are sometimes sending it back to you and telling you you got the wrong date. So date and time should be actually manually entered here. The attending of record should be notified. And for us, since we have a convoluted system in the CQ where there's an attending of record that could be the neurosurgeon or me, you have the CQ attending, you have sometimes a trauma attending. I would say err on the side of notifying everybody, but for us within neurosurgery, just figure out who you need to notify. But I think the policy should be to notify the attending of record. But if that attending of record is a trauma surgeon, I would say you should also notify whoever was a neurosurgeon on the case. And then, of course, the family members need to be notified, hopefully face to face or over the phone. And don't be rude and right away ask for an autopsy. But however, by the time you type your note, you hope that the news will have settled and that you will have an opportunity to reapproach the family members and asking them if an autopsy should be performed. Um, that's different than what the ME will do, even if the ME, so if the ME doesn't take the case, then an autopsy can still be performed. That's at the request of the family members. Um, Organ donation needs to be the OPO, Live On, New York, needs to be notified within 1 hour of all deaths, cardiac death, not only death by neurological criteria. The reason is that they have to still see with the status of the patient if they can harvest cornea and tissue. So don't always think of organ donation as the organs. It's also the cornea and the other tissues after cardiac death. Is it a reportable death or not? That's I copy pasted a long list of what the ME had given me at Kings County a few years ago, but always err on the side of reporting almost every death. Worst case scenario, over the phone, they're going to tell you, no, we don't take the case. But if you omit to report to them somebody that met the criteria, that would be troublesome. I think we just had grand rounds, right, on that, or a few days or weeks ago, where they went over in the ME or the fellow of pathology at Mount Sinai talked about the fact that you can try to learn those criterias or just err on the side of calling more often. Um, Admitting needs to be also notified. That's actually usually the responsibility of the nurse, but different hospitals have different policies. Is it the charge nurse? Is it the nurse of the patient? Do the residents need to make sure that the nurse did their job? So I would err on the side of making sure you communicate the date and time of the death. You tell the nurse, and then they will tell you that they will call admitting, and that needs to be done within an hour. So that is why they are upset at me when I do a brain death declaration and I take time to type my note, unfortunately, because I'm dealing with other emergencies. So within an hour of the death, there is a need for admitting to be notified. And same time frame for leave on within an hour. Core matrix, so that's also, I think, because Epic has an ability to have a few of our notes to go automatically in some kind of registry. So like there's a master list for, I think, trauma, stroke, cardiac events. there's a few things. So if you look at the drop down and you identify something that is pertinent to the patient, just click on it, and that might help with some kind of registry. Usually it's a resident that is authoring the note, so I kept that in my template with your credentials at what time you finalize your note. So remember that might be a date and a time that is different than the actual date and time of the death. So that is why it's separate here. The supervising attending and contract the neurocritical care team. You can replace that with your own neurosurgery phone number. So any questions about the process? Usually we tell the family about death, then we ask about autopsy. The ME is usually notified and they decline most cases unless it was traumatic or um, any of those elements that make them take the case. Don't confuse that just because they took the case, you don't need to call leave on or think that because the patient will undergo an autopsy by the ME that Levon cannot do the harvesting. That's not true. They can coordinate together to do the harvesting after the ME has looked into the cause of death. Oh, and the other process is to once that meeting has that, they prepare for you, but the Vitals is the software that we use, right? I think it's in New York State everywhere. The residents have to, or PAs have to, within 24 hours of that meeting being notified, go on to Vitals with the proper name of the patient, and it says cause of death, and that's where we had an excellent presentation by I think it was MSH neurosurgery grand rounds recently about like immediate cause of death should be listed as I don't know respiratory arrest or cardiac arrest, or she was saying you can jump already to the second one like collapse of the blood pressure due to sepsis due to a urinary tract infection, and do it in that logical fashion, not reverse, and finish with the last diagnosis being an essential diagnosis, like essential hypertension or cancer or something that is not due to something else. So a stroke could be due to atherosclerosis. So if you prefer to do that, you can say atherosclerosis led to a stroke, which led to herniation, which led to the cardiac arrest of the patient. Any remaining question from the last actually from what I just said now and along with what was done at the grand rounds recently about death and declaration?
That's all really helpful. I think in addition to the grand rounds, then actually, walking through the actual EMR, that's also those two together are really helpful.
Yeah, and again, like there might be something that you find too laborious in that template, and you can modify it to your own taste and save it under your own template. All right. So, and again, like as of an hour ago, there was a text message by Dr. Salgado about a patient that we needed to modify. So this is only about the label. Even if your title here says note for a discharge of a dead patient, if you label your note as a progress note or only a discharge summary or only a death note, that will not count as both a discharge summary or a death note. Only the label discharge of the deceased patient will check all the boxes so that documentation specialists are happy. All right, so moving on after that, maybe we can look at my neurocritical care admitting note, which is even more lengthy and probably nauseating for you guys, but a few things will be interesting and you can tell me what you like and don't like. Neurocritical care admission note. So supposedly there's a reason for consultation, like when you're a critical care physician and depending on your background of training as a neurologist or a neurosurgeon, some coders are telling me that it's always good to say that you got involved because somebody asked you to be consulted rather than you self-consulted, or that somehow you got involved and we don't understand why. So that's why there's that little blurb here. It's all a bit weird and probably too much French sounding, and you can condense that. But basically, usually a critical care consult is called upon on a patient that has an organ failure and they need our help. Make sure you have the correct name, date of birth, admitting time. Well, since we're recording, I don't want to open it on a patient, but I wish I could see. Maybe I'll do that. Yeah, if I do F2, at least I see the drop downs. Okay, so the main diagnosis here, maybe it's not comprehensive enough, but at least what I like about using that, and I mean, is that you are fully spelling out the diagnosis. And when you use abbreviations, coders will tell you, I don't know what is an SDH. So a subdural hematoma is fully spelled here. And the compression of the brain, midline shift, all those things are fully spelled out here. So you have both the abbreviation so that we're all talking, I mean, we can all read our notes quickly without seeing every single word, but the coders will be happy that you put all the words there. It's important to have an MRS on admission, not only for strokes, but I think all of us, like in case we transform our progress notes into some kind of REDCap interface or REDCap interfacing with EPIC, I think it's important that regardless of the neurological disorder, we apply those scores on admission. So MRS, you're probably familiar with it. The SOFA score is actually something that is automatically calculated by the EPIC, so that's great. And as you know, in SOFA and Apache scores are our favorite ones in critical care. GCS, the NIH stroke scale. You can even drop down with each element if you really want. I think the stroke team has the element fully spelled out rather than just a number here. That's the admission one. That doesn't mean that's the one that you are seeing at the bedside of the patient. ICH score, don't forget about it. I put a little prompt here for those who don't know the ICH score really well. I think that can help to see it in front of your eyes. Functional score, I know you're not very familiar with it, guys, but there's an application called, what is it called? Neuro Toolkit in one word. I think it's free or $3. And that allows you to have all those coma scales and etc. So for the video, yeah, Neuro Toolkit is in one word, the purple brain looking thing, and it will give you the func score. The functional score is great because it's not only about the 30-day mortality, but also how are the likelihood that, I mean, what is the likelihood of my patient regaining some type of functional status? So is he gonna be independent or totally dependent? And I think it's at 90 days. And when it drives you through the first steps of the func score, these functional scores helps you calculate the ICH size also with width and I mean the two measurements plus also 75% of the of that slice has blood versus like for those little slices where we're like, should I count it or not? I love to use that func score because it calculates really more precisely the volume of the hematoma. So I put those extra little slices where I still see blood, but it's barely 25% of the volume, the total volume of the hematoma. The HUNHES, in case you're not familiar with it, it's written here. The WFNS, as you know, is favored by neurosurgeons, especially the ones who train in Europe, because we prefer the fact that it's more clear and less reliant on so many different domains and so many different things like the severity of the headache and the drowsiness, etc. So the WFNS is cleaner because it's just the GCS and the motor score. The motor deficit, sorry. Modified Fisher, it's also fully spelled out here. I had in a previous version, but I think it was Cerner, even a pop-up. I don't know how to do it yet in Epic, where I copy pasted basically the original publication from Columbia, where you can see those examples of a grade 0, 1, 2, 3, 4. Remember that it's only the lateral ventricles that count. So you can have a Floyd IVH in the 4th or the 3rd. You're not a 3 or 4 on the modified Fisher. It's the lateral ventricles that count. Modified Greb score is for the classification of your IVH, basically 0 to, I think, 33. And the maximum score is for expanded completely casted all ventricles. Spetzler-Martin for the AVMs. So what matters in your notes is truly about the context. Was there any prodromal symptoms, especially for seizures? What was the mechanism of injury, condition at the scene? I know I'm going into too many details, but maybe for medical students, they can use those things and then you can strip it off once you are a PG1 or 2 in neurosurgery and do only what you guys are used to. The ED course matters a lot, and what agents were given, like did they reverse an anticoagulant, that matters. Past medical history, don't go crazy like medical students go into like genetics and stuff like that, which not much matters in neurocritical care, but the stroke risk factors are there, the trauma risk factors are there, the seizures history of seizures are there, what meds they were taking at home, prescribed. Don't forget to do a reconciliation. Antithrombotics and anti-seizure medications are the two categories that I care about. Family history of stroke, ICH, aneurysms. All the other ones are not that important on an HNP for a neurocritical ill patient. Social history, the marital status and their children, their profession, all those things that we often do too fast, but eventually it matters to enter all of those things. The emergency contact is not necessarily the same as the next of kin, as palliative care will teach you. Sometimes we identify who likes to be woken up for the death of their loved ones or a deterioration is sometimes not exactly the next of kin who's older and wants to be only coming at the bedside the next day. So that's why there's a difference between the two. We already talked about that. And now the overnight events, I would say what matters at the bare minimum when I'm running in an ICU, I tell the team, don't tell me about every single vital signs. Please process the information from me. Otherwise, you're just telling me a long list of vitals without processing the matter. So did the patient neurologically deteriorate, or is it respiratory, fever, transfusions, any procedure that happened overnight? Of course, we need to hear about it, a new line, a new infusion, but that's it. I don't need to hear heart rate 80 to 100. Vitals, labs, and medications need to be reviewed, and what is required in a note is just saying so. You don't need to say, you don't need to type them. That's actually wrong to do so, because by the time you sign your note, the vitals have already changed. And so what you need to say probably is that you reviewed it and what did you identify? A trend towards hyponatremia, a trend towards some fever or what have you. That matters way more, and that will be better when you're in court explaining yourself 10 years later, rather than an automatic copy paste of the vitals and the signs and the labs. And at the time of your signature, they were completely different, so you did not address them. So that's my maybe a pet peeve about running in an ICU and hearing all those ranges. And so ranges don't matter. What matters is trends, right? So the heart rate range from 80 to 100. It could be 80, 80, 80, one number spurious of 100, could be 100, 100, 100, and one spurious number of 80. It could be a trend up from 80 slowly up to 100, so the patient is tachycardic, or it could have been 100 all the way down to 80. So from 80 to 100, the range will be reported in the computer as range 80 to 100, and yet I'm gonna start a beta blocker on somebody that is trending up, but I'm definitely not gonna start a beta blocker on somebody that is drifting down from 100 to 80. Ranges means nothing. I want to see the curves, the beautiful lines telling you what is going on. The same way Wall Street people are analyzing and prognosticating rather than looking at a range of the value of their stock options. Code status and goals of care are different, as you know. Code status means what do we do after the arrest, and goals of care are how aggressive should we be. Pre-rounds and time of rounds, that came to light when we had issues with the fact that sometimes our notes were not describing if the exam was from the pre-rounds or after rounds, and sometimes it can become a legal issue, right? when your exam was at 8 a.m. and then your plan is based on something radically different at 10 a.m. So the GCS, I know you know it, EVM, total score, the full outline of unresponsiveness. You have the EMBR score that can be populated for you here. NIH scale, here it says all those different things. The RAS, for those who are not familiar, I guess in neurosurgery you guys use maybe a little bit less the RAS, so please be familiar with it too. It conveys the not only the alertness of your patient, but the behavior of your patient also in a better way than just those gross terms. And you remember, I would rather hear a RAS and a 4 score on my patients rather than AAO times 2, because that doesn't tell me anything about it. So speaking of which, and don't worry, that's the last element that I'm going to detail much. As you know, I like those more detailed versions of which domain of consciousness is abnormal in our patients, so I put that there. Are you alert, meaning you're aware and fully conscious about your environment? Is it difficult to arouse? Is it very difficult to arouse? And is it comatose? And then you can even say what stimulus did you do to rouse them to a higher level. So that was the level of alertness, then the arousability. So he rose from minimal consciousness to partial alertness upon that stimulus. That stimulus is the only scale or gauging that I found in the literature, which is basically the Assisto scale of Yale, YALE, the university in Connecticut, where my colleagues have corroborated that clinical scale with their EEG on quantitative EEG. And that's basically the same as the RAS and what anesthesiologists are using and others about are you spontaneously awake? Are you responding to calling your name, yelling your name, gentle tactile stimulation, repetitive tactile or forceful tactile stimulation, painful stimulation? Did you do a trapezius pinching or a sternal rub or nothing at all? Nail bed pressure, pterygoid pressure, like in a deep coma, nothing rose them up. So that scale to me is more detailed and, as I said, has corroboration to EEG levels. What is the sustain of the alertness is once you rose them to one level, do they crash back down and close their eyes within 2 seconds or not? Once you're beyond 2 seconds, then you can do an attention span, which is within the RAS score, basically the -1 versus -2. 10 seconds of eye contact, that's -1. But if they close their eyes within 10 seconds, then you're a -2 on the RAS score. The level of awareness of their surroundings, are they paying attention to you? As you saw me examining patient, I go to the left, then on the right, and I try to see are they also neglecting on one side. The degree of encephalopathy, I don't have a good term for it. I know bradyphrenia doesn't speak to you guys, but basically it is this slow processing and the way they do things when it takes super long for them to do it. That's usually a sign of global cerebral edema, right? The neurons are not talking to each other in a fast fashion, and therefore they're super slow to do everything. That's different than latency. Latency means there's a delay in the answer. So sometimes you will see with their eyes, they're super keenly aware, but they're thinking of the correct answer. Then they give you the correct answer, or they perform the command properly, but with a delay. That's usually a neuronal issue more than a connectivity issue, like the white matter having cerebral edema. The attention span, I told you, you can do a 20 down to 0 or the CAM-ICU with the saver heart, squeezing the hand. So squeeze my hand when you hear the letter A. If it's another letter of the alphabet, you don't squeeze, and that will give you a true standardized assessment of their attention span. Coherence of the patient is tested last in the CAM-ICU, and you can ask them, or what they are telling you, is it making sense or not? And finally, following commands is dependent on their coherence, but also on their degree of understanding of the language, right? So you can be coherent, but not perform commands properly simply because you're aphasic. So you need to tease that out. The brainstem, you know all your cranial nerves. The pupils, you know that. Brainstem reflexes, corneal gag cough. And that's part of the 4 score. So if you know your 4 score, you don't even need to detail the brainstem here because that's part of the 4 score, the full outline of unresponsiveness. The strength in the extremities, obeying, localizing, withdrawing. I even went into brisk versus slow withdrawal, but that's actually, as you know, not very reliable, to the point that Dr. Weidix in the fourth score removed the withdrawal and went straight from localizing to flexor posturing, flexor extensor, and no movement supine. I think that speaks for everybody. Only once they are following commands are you supposed to use this MRC scale of out of 5. So it doesn't make sense to say 0 out of 5. That's upside down, by the way, sorry. 0 out of 5, you cannot say that on a patient that is obviously comatose, because actually they did not follow the command, so they did not even attempt. So use that other scale here, which is basically based on the GCS and not the MRC, unless the patient is following commands. Sensory deficit, you should probably be binary about it. And finally, limb ataxia, is it coordinated or dysmetric? So you can apply that for each limb. And finally, the mood and the behavior. I know it's very long and you guys are probably falling asleep already now, but frankly, that's what nurses have to do. They have to score all those different domains of the neurological function, and it's confounded also by those other words that they have under mood and behavior. Is your patient cooperative? Is your patient agitated, belligerent, etc.? So here I separated it and I created all those different domains, which to me are sometimes relevant to neurocritical ill patients. All the drips, what matters for us in neuro is analgesia, sedation, antipsychotics, DCI prophylaxis with nimodipine, anti-shivering agents, anti-seizure medications, and the levels of the drugs. It sounds like EPIC can give us automatically a population of our phenytoin, phenobarb, valp, and carbamazepine level, so that's good. Make use of it. The neurovitals, that's something that I had to create also. Like nobody was like understanding why it mattered to put all those things here. But uh, I mean, Emily and Ray, you are probably more savvy than me in figuring out in Epic how to get all of those. But I think you should really leverage Epic to deliver that to you in an automatic fashion. Like where was the ICP range? Where was the last value on the CSF drainage? The EVD drain how many mLs per 24 hours? That's under the Eisenhows, unfortunately. So you need to do so many clicks that's really annoying. And if you work with the Epic critical care designers, maybe we can really have those neurovitals being automatically populated for us. Finally, neuromonitoring, that's something that that I had to create. Obviously, there's no such thing as a template for that, but actually to let you know, Dr. Brendan Foreman and others were coming up with hopefully a lexicon within a year that will be with very specific things here instead of our very inter-rater dependent verbiage that we use for all those monitors. So what is the TCD showing? What is the drug bolt showing you? What is the transcranial Doppler showing you? Those things will be more codified with a lexicon in the near future. Neuroimaging, as you heard me saying maybe at the stroke meeting, I don't think we should be copy-pasting our reports from our colleague neuroradiologists, because that would mean that you're fully endorsing every single word that they're saying, and I hate to sign a note when it says, my name is Dr. Weeks or blah, 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 something else. So I prefer that I'm aware of their reading, but I do my own interpretation, and when you're signing your name, it shouldn't say the name of other doctors above. That doesn't make sense. Neurophysiology should be also personally interpreted. And finally, don't forget the coders love to have those secondary diagnoses, right? So cerebral edema, brain compression, obstructive acquired hydrocephalus, fracture of the skull, hemiparesis, functional quadriparesis. All those verbs are probably logical to you, and all those words are probably better depicted in our GCS and whatever else you put above. But if you don't spell it out, the coders will not know. So here is a long list of what we usually have as neurological secondary diagnoses on neurocritical ill patients. And the usual plan here, I put it like, oh, we're gonna do every 1 hour an NH-oxyl and pupils, or we're gonna do a CT, the position of the patient, Early mobilization, don't forget about that. Analgesia with X, Y, and Z. Sedation with, you want sedatives, do you want uninterrupted sedation? Which one do you prefer? A little bit of, I put the usual stuff here basically. Are you titrating it to the RAS, to the EEG, to the ICP? PT and OT orders needs to be entered here. The precautions, that's something that we always forget. I know we put in the orders, but it's not in the notes, and therefore sometimes the nurses are telling us, why did you put an order for it? I don't understand why it's so important. Well, the seizures are important, full precautions, delirium precaution, one-on-one, elopement risk, etc. Think about all that. So I know my template is way too long, but it's forcing like a PGY1 to go through everything, or a medical student to have to think about all those things. What we usually do in neurocritical care, we order some EEG, some TCD, some non-con CT, some MRIs, and the usual plan. Let's see, what did I populate here? Keep the EVD, raise the EVD, decrease the EVD, osmotherapy, dexamethasone, and seizure prophylaxis. I feel like those are the most common interventions that we have. But I'll stop here to get some input on that. I mean, every single other organ here is basically the same, but a little bit more condensed, since it's not as thorough as the neuro stuff. So look at it and yeah, copy paste whatever you like, and you can remove 90% of that very long admission note. Oh, I see, actually Kate is there. So we can do trauma, and you'll tell me what I wrote that is ridiculously too simple, or that is pertinent. So, oh, by the way, yeah, vital organ failure present, yes or no, that's important, because even if you say patient in coma, the coders don't know that that's an organ failure. It's a brain failure to be in a coma. So the ampoule was ascertained under trauma, the ATLS secondary survey was identified. It's good if you can calculate an ISS or an Asia score. Let's see what I put under trauma. Well-nourished, distress, moribund, traumatic hemorrhage, a deformity, the EFAST, and then list all your injuries here. There's more stuff under bleeding, under hematology probably. Under exam, where is my exam? Here, hematological exam. No hematoma, ecchymosis, petechiae, or overt hemorrhage, including the arterial or venous puncture site. And then the usual VT prophylaxis is right here. So I know I'm not gonna cover every single organ. It's already 4:15, and I probably put you asleep, guys. Oh no, let's jump to the last thing, sorry, before I take any questions. Code status and goals of care, I put it there, and people forget to write about those things. So are you full code or allowing natural death? And goals of care, you can go into many details, but things that have not been documented really well is that the patient lacks decision medical capacity. Well, obviously, when you're in a coma, you do, but if you don't write it down, somebody's gonna say, you never said why your patient was lacking decision capacity, so why did you have to discuss with the family and not the patient himself? The surrogate were updated today about the diagnostic and prognostic developments, name of the informed person. Again, do they have capacity, and live on? Oh, last point about live on. Sorry, I keep finding more things to say, but it's not straightforward for everybody. Don't tell me live on is on the case. End of the story. No, live on needs to be updated. They're on the case is great, but then they need to be updated. Now he's getting better, so actually they can probably sign off. He's regaining consciousness. Or he was losing 2 brainstem reflexes. Today, I see 0 brainstem reflexes, and we're calling for an apnea test this afternoon. Don't call them after the apnea test. Give them an update, even if they're already on the case. So here I created with live on at Kings County a gradation of live on is already on the case, but we updated them of comfort measures are implemented, or we are about to do a withdrawal of life-sustaining therapy, or he doesn't have anything, but he has like a bradycardia, is about to have a cardiac arrest. Well, we updated them, or we're updating them that the patient died of neurological criteria or circulatory criteria. So all those things are way better than just telling me live on is on the case. And this position, you should always also finish your note with, is this patient pertaining to an ICU, an intermediate level of care, going to a respiratory care unit, getting discharged to an LTAC, a SAR, and the family has been educated on the discharge planning, especially for stroke and trauma. We have a few things to inform them about. So yeah, anything that you've noticed that I'm completely off or that you would like me to clarify more?
No, I'll put this recording in the staff folder, but we could also discuss it at a staff meeting too, if you want.
Yeah, I did not cover the coding and billing because we don't have time, but yeah, exactly. We can look at it and discuss what is useful and what is not. Obviously, if you were trying to use this entire thing as a medical student, it would take you 2 hours to type the HNP, but I think there's a few things that are useful to remind people. Those lines and drays are automatically, so those numbers, I did not type them, so that automatically gives you the all the lines and drains and access of the patient and how old are they, so that you don't need to calculate, oh, it's a Foley, day 3, etc.
All right. Great, thank you. Thanks, Dr. Kapinos.
All right, bye.
Thanks for stepping in at the last minute too. I think
No, it's
Laura was
fine.
supposed to go right today. Initially.
Yeah, it was super helpful. Thank you.
All right, cool. I'm gonna stop recording.